Welcome to Integrating U = U into Clinical Practice in U.S. Fast-Track Cities. This clinician-oriented activity is sponsored by the International Association of Providers of AIDS Care, or IAPAC, in partnership with the Prevention Access Campaign. This module is based on widespread support for the belief that people living with HIV who achieve and maintain viral suppression through the optimal use of antiretroviral therapy, referred to as ART in this module, cannot transmit the virus sexually to their HIV-negative partners. Research institutions, public health agencies, and professional medical associations around the globe recognize and support the public health benefits of promoting a message that undetectable equals untransmittable, or U = U. Integrating U = U into clinical practice in U.S. fast-track cities is an online activity for HIV treating specialized and primary care clinicians featuring 3 modules. A review of the scientific evidence underpinning U = U. Testimonials from people living with HIV regarding U = U. Recommendations for provider-patient communication about U = U. The goals of this clinician-oriented activity are to promote the integration of the U = U message into clinical practices, designate an HIV diagnosis by promoting the U = U message. The target audience for this activity includes nurses, physicians, and physician assistants who are both HIV specialized and primary care providers. We wish to thank this activity's course director, Dr. Amanda Castell, from George Washington University in Washington, D.C., as well as a multidisciplinary planning committee comprised of nurses, physicians, psychologists, public health specialists, and patient advocates. IAPAC requires instructors, planners, managers, and other individuals in a position to control the content of this activity to disclose any real or apparent conflict of interest they may have as related to the content of this activity. All identified conflicts of interest are vetted and resolved according to IAPAC policy. A disclosure of conflicts of interest is hereby provided, reflecting reports of financial relationships or relationships to products or devices, faculty, planners, and managers and/or their spouses and/or life partners have with commercial interest related to the content of this activity. Upon concluding this module, participants will be able to explain the scientific evidence behind the U = U message, define the destigmatizing effect that the U = U message has on people living with HIV and their sexual partners, effectively communicate the U = U message to people living with HIV as well as those affected by HIV within a clinical setting. The George Washington University School of Medicine and Health Sciences is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The George Washington University School of Medicine and Health Sciences designates this enduring material for a maximum of 3 AMA Physician Recognition Award Category 1 credits. Physicians should only claim credit commensurate with the extent of their participation in the activity. Education Review Systems is an approved approver of continuing nursing education by the Alabama State Nursing Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. This program is approved for a maximum of 3 hours of continuing nursing education. Educational Review Systems is also approved for nursing continuing education by the states of California and Florida, as well as the District of Columbia. IAPAC acknowledges educational grant support from Janssen Therapeutics, Merck & Company, and Vive Healthcare. The content for this activity was developed by and reflects the views of the activities planners, not those of the commercial entities providing educational grants. Let's review the evidence behind the U equals U message. Researchers now predict that people living with HIV who initiate and remain on modern ART can expect to live a near-normal lifespan. In fact, modern ART has transformed HIV disease into a chronic and manageable health condition for people living with HIV. The evidence supporting U equals U is exceptionally strong. The first of 4 international trials on the secondary prevention benefits of successful ART, called HPTN 052, was stopped early in 2011 due to the magnitude of the effect. Later analysis found zero-linked HIV transmissions between a person living with HIV and their HIV-negative partner when viral suppression was achieved and maintained. In HPTN 052, 1,763 participants living with HIV were randomized to begin antiretroviral therapy early or to delay ART until after 2 consecutive CD4+ tests fell below 250 cells per milliliter cubed or the emergence of an AIDS-defining illness. The study endpoint was genetically linked HIV infection of the index participant's HIV-negative partner. Nearly all the couples were in opposite-sex partnerships. Overall, early ART initiation was associated with a 93% reduction in genetically linked transmissions. However, further analysis found that when HIV was stably suppressed below 200 copies per milliliter in the HIV-positive index participant, 0 transmissions had occurred. This underscores the importance of ensuring that patients achieve and maintain full HIV suppression, which can be facilitated by evidence-based behavioral and other treatment adherence support interventions. People living with HIV who maintain good ART adherence should achieve full viral suppression within 24 weeks of initiation, some as early as 8 weeks. Because viral load is an important indicator for ART response, multiple HIV treatment guidelines panels recommend regular viral load monitoring, although the frequency of monitoring may differ in resource-limited settings. In middle and high-income countries, undetectable typically means less than 20 to 50 HIV RNA copies per milliliter. In the landmark TasP studies, no transmissions were observed with HIV RNA less than 200 copies or less than 400 copies per milliliter in the Argentinian and Thai sites of the Opposites Attract study. In some low-income countries or regions, viral load monitoring may differ considerably from high- and middle-income countries. Viral load assays may be administered less frequently and use higher HIV RNA cutoffs, such as 400 copies or even 1,000 copies per milliliter. In this case, clinicians should advocate more frequent and sensitive testing when possible, and patients should be informed that the prevention treatments of ART have been confirmed only when people living with HIV achieve and maintain viral suppression below 200 copies per milliliter. However, because highly adherent patients generally achieve suppression below 400 copies per milliliter, treatment adherence support for patients should be prioritized and promoted. Beyond HPTN 052, 3 other studies found zero-link transmission between people living with HIV who achieve durable viral suppression and their primary HIV-negative partners. These findings extended to men with male sex partners. In these studies, an undetectable viral load was defined as less than 200 copies or less than 400 HIV copies per milliliter. Negligible risk, as it is technically reported, means that the risk is small enough that it does not require consideration. Terminology is potent, however, especially with regards to HIV-related stigma. Since the risk of transmission is negligible, experts promote a message that there is a zero risk of HIV transmission if a person living with HIV is on ART and has an undetectable viral load. However, durable viral suppression is required, which may mean more frequent viral load monitoring for some patients. Moreover, providers should recognize the importance of preventing and monitoring for other sexually transmitted infections, or STIs. In HPTN 052, Partners and Partners 2, the presence of STIs did not increase the risk for HIV transmission. Nonetheless, condoms should be discussed to minimize STI transmission and to mitigate HIV transmission when a person's viral load is unknown or detectable. Although some studies have reported a discordance between plasma HIV RNA levels and viral loads in semen and vaginal fluids, none of the studies on TasP found that HIV transmission occurred when HIV was suppressed in the blood, regardless of the presence of HIV in genital compartments. When an HIV-positive partner's viral load in blood is uncertain or detectable, however, other prevention methods such as condoms and pre-exposure prophylaxis, or PrEP, should be encouraged for any HIV-negative partners. PrEP is a biomedical prevention intervention that can prevent HIV acquisition for people who do not have HIV but who are at very high risk of acquiring HIV. Studies have shown that PrEP reduces the risk of getting HIV from sex by about 99% when taken daily. Because PrEP only protects against HIV, condoms are important for the protection against other STIs. A common concern for both clinical providers and people living with HIV are viral blips. These are periodic but normal increases in HIV RNA levels from 50 to 200 copies per milliliter. They are quite common in people who are highly adherent to ART regimens, occurring in roughly 20 to 60% of individuals who are durably suppressed. Viral blips are generally a result of laboratory variation, temporary drug concentration changes, or transient bursts of immune activation and are not a cause for concern unless they continue over an extended period of time. Clinical providers and people living with HIV also frequently ask about the impact of missed doses on U=U. Fortunately, modern ART is quite potent, which alleviates the concern about occasional missed doses. Treatment adherence monitoring is important for clinical providers, however, and patient self-report along with pharmacy refill records offer relatively accurate methods for assessing and responding to adherence issues. Changing ART regimens can lead to temporary viral load increases, and experts recommend viral load testing after initiating a new regimen. Testing should ideally occur 2 to 4 weeks, but no more than 8 weeks after a regimen change. Until full viral suppression is confirmed, condoms and/or PrEP for HIV-negative partners can mitigate the risk of HIV acquisition. Viral rebounds also occur in some patients, generally due to poor treatment adherence or the emergence of drug resistance. A viral rebound is characterized by consistently detectable HIV levels over 200 copies per milliliter after periods of viral suppression. As with regimen changes, condoms and/or PrEP for HIV-negative partners are recommended. The 3 basics for maintaining durable viral suppression are treatment adherence, laboratory values, and connection to holistic healthcare. Adherence is essential to maintaining an undetectable viral load. Routine monitoring of viral loads is essential for clinical decision-making. However, a continuous connection between people living with HIV and whole-person healthcare, which views them as more than laboratory values, is essential. HIV-related stigma is highly prevalent among people living with HIV and is independently correlated with increased depression and poorer treatment adherence. HIV-related stigma can also inhibit disclosure, openness to sexual and romantic relationships, and increase exposure to violence and fear of legal prosecution. U=U matters greatly because it can help reduce stigma surrounding HIV and the reality that people living with HIV are often seen as infectious. People living with HIV, clinical providers, and public health experts anticipate that the spread of knowledge about U=U will increase HIV testing and treatment uptake, treatment adherence, and long-term engagement in HIV care. Treatment as prevention data have generated significant support for U equals U among research and medical circles, citing zero risk of transmission, increased utilization of HIV services, and its destigmatizing effect as critical to public health efforts to end HIV as a public health threat by 2030. In fact, leaders across government, public health, and medical associations support the core evidence-based fact underpinning U equals U, that an undetectable viral load truly does render HIV untransmittable. In conclusion, the evidence behind U equals U is solid, with combined data from 2008 through 2016 showing zero-linked HIV sexual transmissions after more than 100,000 condomless sex acts. These data include heterosexual and same-sex male serodifferent couples where the partner living with HIV had a durably undetectable viral load below 200 copies per milliliter. U equals U should be integrated into clinical practice by clinicians and communicated consistently to people living with HIV following a new HIV-positive diagnosis and when a patient achieves durable viral suppression. U equals U is a destigmatizing and transformative message for people living with HIV and their partners, and they have a right to such knowledge delivered by their clinical providers. Module 2 of this e-learning activity features testimonials from people living with HIV about what the U equals U message has meant to them. Please advance to Module 2 now.